Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have a patient who attended with a blocked right ear and they had been suffering for a few days prior to attending. They did admit to using a cotton swab, also known as a Q-tip in the States and a cotton bud in the UK. And that had only served to further push and impact this earwax deeper into the ear, up against the patient's eardrum. And this wax plug was very dry, very hard, so it was severely impacted. And what made the procedure a bit more difficult was the patient had a collapsed ear canal entrance, and in addition to that, they had very petite ear canals. So even once you enter the ear, beyond the collapsed canal entrance, the whole anatomy of the ear canal was just a bit petite, a bit smaller than usual, so it just made the remove of the wax a bit more difficult. I initially used microsuction, but this wax plug was too dry, too hard. I wasn't able to get a suction grip. So I've now just inserted a St. Bart's ear hook, and I managed to insert the hook right into the core of this wax plug. And I was hoping, as I extracted the hook, that the whole plug will come out in one singular piece. But instead, the hook just dissected this plug of dry wax and dead skin. So I've just had to go back in with microsuction and just suction up some of the broken up pieces of this wax plug. And again, I'm just going in with the hook. I've managed to get it into the core, and it was a bit frustrating for that reason, because I managed to get it into the narrow ear and I managed to insert the hook into the core and embed it. And I was typically, when you do that with a wax plug this dry and hard, it just comes out in one go. But once again, it just dissected it, which still helps me to remove the wax plug, because by breaking it into little pieces, I can then go back in, almost like a hammer and chisel effect. You're using the hook to break up the wax, and then you're using the suction to suction up the little pieces. And you can just tell how narrow and how petite this ear canal is, because this is a standard Zollner suction probe, but it's taking up a lot of the space inside the patient's ear canal, so there's not much room for manoeuvre and manoeuvrability of the suction probe. I'm just working anteriorly here. Now the reason why this was lodged is because the plug extended quite deep into the ear. You'll see that upon removal of the plug once I get it out. And it was lodged beyond a region of the ear canal called the isthmus. So as the ear canal approaches the eardrum, about a half a centimetre away, most of our ear canals narrow slightly, and then it widens back out. And when it widens back out, it creates a recess on the front part of the ear canal, near to the eardrum. We call that the anterior recess. Think about it like a little alcove. And it also creates a trench, a dip, a basin, a floor of the ear canal near to the eardrum. And if you lodge earwax beyond the isthmus, the wax plug then expands and fills up the recesses, which makes the removal much more difficult, because you're having to remove a large piece of wax from a narrower aperture. So I've just gone back in with the hook. I used the microsuction to bring this wax plug forwards, and it's now created a bit of an opening at the roof of the ear canal. So again, I'm just going to go in, I'm going to glide the hook behind this wax plug. I'm just trying to leverage it forward. You can see it's coming out in bigger pieces now, but again, it's not coming out in one single large piece. So it's just some debris, some broken up pieces of wax that I'm just going to mop up and hoover up with the Zollner suction probe. Interestingly, although this was the patient's worst ear in terms of their symptoms, it was their left ear that was more complex to remove. And if you stay tuned, you'll see the left ear. And so that's quite a long piece of wax that I removed. And I thought that would be it. But as you can see, there's still quite a lot more. And this plug is enveloped with a lot of dead skin. And you will be able to see that, hopefully, as I remove it. You'll see the perimeter of this wax plug. It's enveloped, it's engulfed with a layer of skin. You're able to see that white, glossy skin just there. So that skin was actually attached to the ear canal wall, and it came away. That's the patient's eardrum, nice and healthy. You can see there's some blistering there, some red patches, and that's because the wax plug was attached to the canal. That skin that you saw that was enveloping the wax plug was also attached to the canal wall. So as I brought it forwards, the dead skin pulled away, just leaving a bit of blistering, but it's fine. Just using a fine end suction probe here, just some, as I say, some crusted dead skin on the posterior canal wall. This is the back part of the ear canal. And I'm really happy with that. Nice healthy eardrum. And we're going to move on to their left ear. So this left ear, the canal wall was even more collapsed. Now, what's a collapsed canal? Typically, the canal collapsing occurs in the outer third of the ear canal, the cartilaginous portion. The inner 2/3 of the ear canal is made up of bone, so it's rigid, and it's very rare that that's going to collapse. So it's the cartilaginous portion, the outer third, that can fall upon itself, really, and it can happen due to chronic ear infections. It can happen just with age, so the cartilage just weakens and it falls upon itself. It can no longer support itself. It's similar to our nose. So with our nose, the lower 2/3 of the nose is made up of cartilage, and the upper third of the nose is made of bone. And as we age, as we get older, the cartilage can weaken, and gravity then takes hold of this, and it can cause people to have a droopy tip of the nose. And similarly, it can happen with the ear. The canal, because it weakens the cartilage, it collapses and it falls upon itself. Also, the posterior canal wall, the cartilaginous portion, that can still grow. It kind of continues to grow all the time, actually. Very slow rate, mind you. And sometimes it grows too much or out of line, it can then, again, just fall upon itself. So additional growth of that cartilage can also cause itself to fold upon itself. There is surgery that can correct that, so patients can have that cartilage trimmed and repositioned. I suspect it's ENT only when you want to do that if it's causing the patient severe problems. Having your earwax removed once in a while wouldn't really justify that surgery, I wouldn't have thought. But if you're suffering from chronic ear infections, for example, or you're having difficulties inserting a hearing aid because the canal entrance is collapsed, that of course is another potential reason why ENT may operate. So they perform a myotoplasty. This patient will probably need to have their ears de-waxed every 12 to 18 months, and that's the last time they've had it done. So it's not a chronic problem where they're having to come, although 12 to 18 months, of course it's some people, considering some people never have to have their earwax removed, you could say it's a chronic problem, but you have some patients that have to attend every 3 or 4 months for various reasons, and I think that's where it's probably going to be more of a common practice to perform procedure if someone has to come on that regularity to have their ears cleaned. I have one patient that used to have to come every couple of months, and they wear hearing aids, and because of the impaction, they used to also have ear infections as a result of their collapsed canal, and they are now considering surgery. They've been offered the opportunity to have surgery, and they're just weighing up the pros and cons. So again, I'm just using the microsuction probe. Now, the reason why I felt this was more complex than their right ear is that I think the canal was even more narrower, it's more petite. So I've just brought the wax plug forwards, and then I'm just trying to prise the hook behind, and I'm leveraging it forwards. When we leverage this ear hook forwards, we've got to be careful. That tip, although it's rounded, it still can cause some damage. And if you embed that hook too deep into the ear, or if you rotate it too far, so it's up against the canal wall, as you bring it forwards, it can graze and cut into the canal wall or the floor of the ear canal, and cause patients severe pain, otalgia, and can also cause a lot of bleeding. So you do have to be careful. I also just doubled up there with a St. Bart's ear hook. It did remove a little bit of wax for me. Now, once I've removed this final plug, you will see some blistering on the posterior canal wall, similar to the region where I removed that crusted dead skin from their first right ear. In fact, it's probably the exact same region. So that blistering, it wasn't caused by contact to the canal wall. Again, this patient had some skin attached to the wax plug, and it was also still adhered to the canal wall. And as you prise this wax plug away, the skin also comes away. It can cause a bit of blistering. So there was no active bleeding, but you'll see it's a bit red, and that will settle very quickly. So I'm just trying to wriggle this through. And the reason why I didn't use forceps, just in case you're wondering, is because similar to when we did the right side, even with the hook, the wax plug just fell away. This was a bit firmer, so you can see with the hook I did manage to get a big chunk out there actually. So there's that blistering on the back canal wall. There's just some dead skin that I'm going to mop it. So as you enter the ear, so it does widen. So, this patient has not only got a narrow entrance, but the midsection of the canal wall is also quite petite. But once you're beyond that midsection, the ear canal does widen to a good size. And again, it means that we're having to bring through a large wax plug through a narrow aperture. There's a slight attic retraction of the eardrum. The patient did report cold, and they are taking some decongestion, some nasal decongressions. So really happy with that. I hope you enjoyed that video, guys. Do stay tuned. I've got loads more videos to upload in due course. Take care, keep well, and speak soon. Bye.